everyone, and welcome to our webinar. Today, we're going to talk about inequities in health and health systems in Latin America and the Caribbean. And the occasion to do this is a special issue that the International Journal for Equity and Health had the privilege to publish with guest editors Daniel Maceira, Pablo Gaitán Rossi, the wonderful and super talented Daniela Rodriguez, and myself. Joining us today is also Mariana Calderon, Matthew Poirier, and Ariel Frisancho, who are authors. In addition, we have Giselle Almeida from PAHO. But before we start, I just wanted to say a few words about Latin America. Latin America is the most understudied and most unequal region in the world. It is culturally and ethnically diverse. It has burgeoning economies, it has high levels of violence, growing political instability, and it has striking levels of inequality. It is, all in all, a region that is very difficult to define and even more difficult to understand. The region's health systems are deeply fragmented and segmented, and this poses great challenges to the provision of quality care and to the overall equity levels that the Latin American society can expect at large. Market, social, political forces, and others continue to push towards the poorly regulated privatization of public healthcare in many countries within the region. And this is happening in detriment of public healthcare services where management capacities are limited. This is the first collection of papers in what we hope to be an ongoing thematic series that can help us dive deeply into the reasons and the causes of inequality in the region, and also the ways that the new and innovative ways in which they are being addressed. This first collection of papers showcases how different countries have tackled, with different levels of success, the incorporation of innovative health systems reforms that are aimed at strengthening governance, participation, and the response to the growing epidemiological and demographic demands of its diverse population. We at the International Journal for Equity and Health are delighted that this special collection will remain open to house future papers from Latin America and the Caribbean, and we hope that the journal will become the go-to place to understand Latin American health systems and inequalities within our societies. The region of Latin America and the Caribbean has important experiences and lessons to share with the world. So we look forward to learning more and about how practitioners and researchers continue to experiment and to innovate, and how they struggle to reach equity and health, not just for some groups, but for everyone within the region. This thematic series is then a platform for the region and for the lessons that other countries and other settings can learn from us. Thank you.
Now let us begin with the presentations. We're going to start with Mariana Calderon Jaramillo. She's a sociologist with a specialization in demographic methods. She's a master in social studies of science, and she's interested in gender studies, sexual and reproductive health and rights. Also in feminist studies of science and migration. Currently, she's a qualitative research analyst at Pro Familia's research direction at Bogota, Colombia. Mariana,
Thank
please.
you. Thank you, Pablo. I'm going to ask Nanuka if she, thank you, Nanuka. So first of all, I want to thank you for this important invitation. It's really good for me to be here with you. Next, please. The other one, Nanuka, please. Yes, thank you. First of all, I want to share with you some details about Pro Familia. It is a Colombian non-profit private organization that for the last 55 years has been the leader in the provision of sexual and reproductive health services in our country. And our position as leader has driven us to face many challenges and to permanently work in order to eliminate barriers and have sexual and reproductive services for the most vulnerable population, like migrants, armed conflict displaced, people with disability, young, indigenous, Black, and Afro-Colombian population. Since 2018, we have been working in a project that by then was funded by the Kingdom of the Netherlands Embassy, oriented toward the adaptation of our services for trans people. The article published in this edition of the International Journal for Equity in Health summarizes these findings of our research conduct in order to adequate our services. Next, please. So I wanted to give you a background about this topic. We recognize that historically trans people have faced different forms of violence, discrimination, and stigma, and unfair access barriers when dealing with healthcare providers, as well as social exclusion from information systems, healthcare programs, and legal frameworks. Among the most common healthcare barriers found by different studies are the lack of healthcare coverage, denial of essential services such as sexual and reproductive health services, lack of knowledge and training of healthcare staff, social prejudice, and imposition of either masculinity or femininity by healthcare providers, depending on patients' assigned sex at birth. The next one. Okay, so prior research demonstrates how trans people have been excluded from sexual and reproductive health services and outline the fact that they have been exposed to different forms of violence by healthcare services providers. There is a broad evidence on the existence of multiple access barriers, as the one that I just mentioned, that generate various forms of violence, discrimination, and stigmatization towards trans people who seek healthcare services. Nevertheless, to our knowledge, a limited number of studies have addressed the issue on how to tailor sexual and reproductive health services to trans populations and to eliminate barriers for equitable care. Next one. Our research question was related to our problems, the problems that we were facing in Pro Familia. So we were working, and we still do, for adapting our services to trans people needs, identities, and circumstances. In order to meet this, my colleagues and I performed an operative research oriented to adjust sexual and reproductive healthcare services to trans people. From a qualitative perspective, this study was oriented by the following research questions. The main one was how have trans people experienced access to sexual and reproductive healthcare services, and there were also two other questions related to which have been the barriers they have faced, and also what are their expectations around overcoming these barriers. The next one, please. Thank you. Research about the research methods, I want to share with you that we wanted mainly to hear trans wishes through a qualitative study based on trans voices and experience in 4 major cities in Colombia: Barranquilla, Bogotá, Cali, and Medellin. These cities were selected because of the important presence of trans communities, but also because, according to Colombian Demographic Health Survey of 2015, these present different acceptance and recognition levels of this population. Data was collected through focus group of discussions with trans people and semi-structured interviews with trans people that had previously come into Pro Familia clinics. In total, we performed 5 focus groups and 13 in-depth interviews with a total participation of 67 trans people. It is important to mention that this fieldwork was only possible because of the support of several trans organizations that help us to ensure participation and create new relations of confidence between us as healthcare providers and them as historically neglected population in these services. The next one. Amongst the main barriers faced by trans people at healthcare services, this research found costs, lack of insurance, stigmatization, discrimination, and abuse by healthcare providers. Regarding their healthcare needs, it was evident that trans people need same sexual and reproductive services used by all the population, but they also need trans-specific services, such as sensitive assistance for their transition, endocrinology assistance, and sex reaffirmation surgeries that usually are not covered by healthcare insurance. in Colombia. Next, please. Thank you. For example, a participant from one of the focus groups of discussion expressed their frustration with other healthcare services that has used before, but also his need of services adjustment as follows. I'm going to read a quote. It is like there is only men and women. You know what I mean? And then there is only treatment for those people, men and women. But when we get there to the clinics, it's like something new is coming. I feel that it shouldn't be like that. I mean, they should understand that there is a human diversity in the world and that they should treat us all the same. Next one, please. Next one. So this evidence allow Profamilia to adapt their services through the implementation of a specific health program for trans people. Nevertheless, we are aware of the complexity of trans people's sexual and reproductive demands. That is why we are now conducting a research closely to be launched related to abortion on trans men and non-binary population, which is also an urgent topic because of the lack of awareness regarding trans male and non-binary people need to safe abortion services and the generalized imaginary that only women can get pregnant. The research performed gave way to the establishment of strategies for the construction of a healthcare attention program for trans people. Such strategies finally became our roadmap that allowed us to organize our internal structure. We wanted to list such strategies hoping that they can be useful for other health actors that also wish to adjust their healthcare services. You can see these strategies in the slide. First of all, community incidence strategies that are important to improve and invest in the strengthening of trust amongst trans people. Second, awareness and inter-training process to eliminate violence and discrimination in the health service delivery through awareness campaigns. Third, technical training for healthcare professionals to develop high quality technical and training skills in the clinical health approach. The fourth, building an interdisciplinary team. This is really important because we need different approach in order to understand the diversity of this population and also the diversity of their needs. The importance of conducting research and always more research, more evidence about how we can get better services to their needs and how other service providers and government sectors can participate in this process. And finally, external advocacy to generate political incidence process that can promote the protection of trans people's rights and health. The next one, please. Our main goal is to guarantee all people's sexual and reproductive rights in Colombia, by recognizing that sexual and reproductive healthcare services should be adapted to people's needs rather than suppose that people have to adapt to healthcare services. We as providers must follow trans people example and start our own transition process. Gracias.
Thank you, Mariana. Very interesting paper, actually. It's a fantastic example of how health systems need to change and how to transform, especially on how to do trans-specific services and the kind of interdisciplinary teams we would need in order to do that. Thank you for your presentation. Now let's go let me introduce you to Mathieu Poirier. He's an assistant professor of social epidemiology in York University School of Global Health. He's also a member of the WHO Collaboration Center on the Global Governance of Antimicrobial Resistant and research director for Global Legal Epidemiology with the Global Strategy Lab. He previously directed vector-borne disease research for the Notre Dame Haiti program and analyzed the global and regional impacts of the Framework Convention on Tobacco Control. His research ranges from evaluating international law to developing health equity metrics and generating policy-relevant research on socially and politically determined inequities in health. Mathieu, thank you for being with us.
All right, thank you very much for the kind introduction. I'm very happy to be here. Let me share my screen. Okay, hopefully you can see everything all right. So today I will be talking about a paper called Geographic Targeting and Normative Frames, revisiting the equity of conditional cash transfer program distribution in Bolivia, Colombia, Ecuador, and Peru. Like Paulo said in the introduction, I'm an assistant professor of social epidemiology at York University in Toronto, Canada, and I'm part of the Global Strategy Lab, directing Global Legal Epidemiology program. So I won't have time to go over all of the results that are in this paper, but I want to go over briefly what it is that it examined and some important findings. So it's mostly looking at conditional cash transfers and the equity and how they were distributed and targeted. And I won't go over in depth what this diversity of programs can consist of, but generally they're intended to promote things like school attendance and visits to clinics for women and children, and there's many other program outcomes as well. But importantly, there's a cash component. There is a cash payment to offset opportunity costs that are associated with staying in school or going to a clinic appointment, getting a vaccination, something like that. And the 4 countries that I looked at, it was a diverse case purposive sample. And specifically, I was trying to get some variation in the targeting mechanisms. So you can see here that for the 4 countries, there were a series of conditional cash transfer programs that were focused on health, which was the important part. The Bono Juana Zordoy in Bolivia, Más Familias en Acción in Colombia, Bono Desarrollo Humano in Ecuador, and Juntos in Peru. And importantly, there was a mixture of 2 programs that were universally rolled out to the entire country, and 2 programs that were geographically targeted to some regions over others. The target population in Bolivia was all pregnant women who report not having social protection coverage. In Colombia, there's a CISPEN household vulnerability index that is used to target households based on health, education, household, and vulnerability indicators in specified municipal groups. The CELBEN index, which is based on infrastructure, demographics, education, and household assets, is used in Ecuador. And Peru had actually several different iterations of district and household level indices based on health, education, demographic, and wealth indicators. So there's a lot of variation in how these were targeted. So what I was interested in is that policymakers deal with a lot of uncertainty in how to target these programs. And that deals with both the socioeconomic status and the health status of populations. And it's often unclear when these programs are rolled out, whether they're actually intended to address access to care or health outcomes, if health is really the focus of targeting, or if they're trying to target socioeconomic status, whether relative poverty or absolute poverty within a country is the primary motivating factor for policymakers. And the other thing, like I said, is that in practice, targeting can be operationalized through targeting some geographic areas within a country, or through active or passive means testing. Asking what the relative standing of a household or of an individual is in the country or region. And so this study was probing the role of normative frames and bounded rationality in targeting CCT enrollment. So I'll just quickly go over some highlights, some results. First of all, I don't want to throw too many numbers at you. So this is a decomposition of what's called a generalized entropy index. And you're actually not seeing the index here, you're seeing the percentage of inequality that can be decomposed to either a component that's explained by geography, by the sub-region in which you live, or by the quintile of socioeconomic status in which your household is part of. So essentially, how much inequality in 4 health outcomes is due to geography or due to socioeconomic status. And so one health outcome, or access outcome rather, I looked at was DPT vaccination. This is the only outcome that had more inequality due to geography rather than socioeconomic status. The other 3 outcomes of underweight, stunting, and child deaths, a greater percentage of inequality can be decomposed to socioeconomic status rather than geography. And the lines you see are actually the points in time in which the conditional cash transfer programs were implemented in every country. So the lines are different for every country because they were implemented in different points in time. And we see that generally over time, the percentages are going down, although this study was not intended to address that. The other set of numbers I will show, these are concentration indices. So the concentration index measures the amount of inequality that is due to socioeconomic status. And a negative number means that it is concentrated among the poor. A positive number means that it's concentrated among the rich. Actually the number I want to focus here on is in the column that says CCT coverage, because this is a rare case where I actually want to see a large negative number. I want to see concentration among the poor because it means that the programs are being targeted progressively to populations that need it. And what we see is that Bolivia is actually the only country that has a CCT coverage that has less progressivity than there are inequities in health. So the coverage is less concentrated among the poor than the poor health outcomes are. On the other hand, in Colombia, in Ecuador, and Peru, we see CCT coverage that has higher inequality than the health outcomes that they're targeting. So that tells me that they are sufficiently progressive to, in theory, address the health outcomes they're intended to address. And now that's all the numbers I'll show you, but I'll go to a couple of maps and selected results. So first of all, I find that higher CCT coverage in subregions with more vaccine coverage. So regions with more vaccine coverage also have higher rates of CCT coverage. And I also see higher rates of CCT coverage in geographic areas with higher rates of underweight, stunting, and child deaths. So that's a good thing. That means they're getting to where they need to get. I also see that relative socioeconomic status ranking of a subregion within a country appears to be guiding policymakers more than the absolute prevalence of poverty in a subregion. So relative rather than absolute socioeconomic status appears to be guiding these, this targeting mechanism. I also put together a simple predictive model that's constructed using information available to policymakers at the time of implementation. So it's actually lagged a year. And just by throwing together 3 variables of health outcome, of inequality in socioeconomic status, and absolute socioeconomic status, that targeting that I constructed performs as well or better than observed enrollment for every country, year, and outcome. Also comparing actual CCT targeting to a redistributed targeting model using perfect knowledge. So in an ideal world, Peru had the highest rate of mistargeting for every outcome, and that was driven by the many subregions with no CCT enrollees. Also, the actual CCT distribution for Bolivia is about as well targeted as the simple predictive model, but Colombia and Ecuador would reduce their mistargeting by as much as half, and Peru would reduce its mistargeting by 50 to 75% if the simple predictive model was used. And just to wrap up, I have some policy implications to take away from some of these results. So first of all, household socioeconomic status appears to be a more important driver of malnutrition and mortality than geography is in every country and year that I analyzed. And although progressivity was achieved with both universal and geographic targeting, universal rollout with means testing appears to outperform geographic targeting. I also find that capital subregions were under-targeted in 3 of the 4 countries as compared to what we would expect with perfect targeting. So that's one data point among many that suggests that these programs are not being targeted to, for example, where policymakers are located. I also find that socioeconomic status and relative rather than absolute socioeconomic status appears to be the dominant normative frame at work in the design of CCT program targeting. And so if I'm just going up one more level, I would say that that every CCT program in this study has achieved progressivity in targeting. And so therefore they are all successfully promoting greater health equity. I also find that geographic targeting, it may be a low-cost method of rationing scarce resources. So I do understand why it's used, and especially in situations with limited information and limited resources. But it's not a replacement for means testing if CCT programs are meant to be targeted to populations with the highest levels of ill health in the country. And finally, if solidarity with the poorest and sickest populations in a country is a fundamental feature of CCT programs, excluding the most vulnerable women and children that happen to live in more affluent subregions directly undermines that goal. So I think that's a really important takeaway, that we can't be leaving people behind who live in geographic regions that are relatively affluent, but the households themselves may be actually quite poor in comparison with the rest of the country. So it's important to remember those populations when designing the targeting mechanisms. So that is all I have for the summary of the paper, and I'm looking forward to discussion later. Thank you.
Thank you, Mathieu. That was a very compelling presentation. Actually, it was very interesting to see how important indices on CCT, since they're like a key instrument of social policy in Latin America. And I especially liked the discussion on ways of targeting, different ways of targeting the CCTs and the important indices that you are presenting. Thank you, Mathieu. Now let's talk about social exclusion in Latin America and the Caribbean. Let me introduce you, to Ariel Frisancho. He's CMMB Peru's country director. He's an MD and MSc on health policy, planning and financing. He's a specialist on rights-based approaches, citizen participation, community health, health governance, and accountability. He's author on these issues at diverse international publication, Care Peru's manager of social rights programs on education, health, nutrition, and water and sanitation. And he is also an international cooperation offices director at Peruvian Ministry of Health from 1995 to the year 2000, and member of the steering committee of the Community of Practitioners on Accountability and Social Action in Health. He was also Peru's Foro Salud president from 2012 to 2013, and member of Foro Salud's directorate until from 2004 to 2016. And he's a member of he was a member of World Bank's Civil Society Consultative Group on Health, Nutrition, and Population. So it's our pleasure to have Ariel with us. Ariel, please.
Thank you very much, Pablo. Thank you, special thanks to the International Journal for Equity in Health for the opportunity of coming closer to the realities of Latin America in terms of health and equity. I think this has been a paramount edition, and we are very honored, Jenny, Walter, and me, myself, for being part of it. This article, Social Exclusion and Universal Health Coverage, Healthcare Rights and Citizen-Led Accountability in Guatemala and Peru, has been written by the 3 authors. Main author is Jenny Samuel, and here's her email for any later inquiries. The next one, please. So we have analyzed all the literature made along 5 to 10 years around two emblematic case studies on citizen-led accountability, one in Guatemala and Peru. Reviewing challenges faced by indigenous people to receive universal health coverage in Latin America, we analyzed social exclusion and its negative effects on health systems and how this could undermine progress towards universal health coverage. We have analyzed two experiences, similar experiences on citizen-led accountability for indigenous populations that have been propelled, spearheaded by women and men, indigenous women and men elected by their communities with the participation of one-third actor in the case of sex in Guatemala and in its moment care and Foro Salud in Peru, that had similar characteristics. The citizen monitors that were in charge of visiting the facilities and monitoring what it was happening there, talking with the people there, were elected by their communities. They had a capacity building process so they could better know how health system functions and which are their entitlements being health services users of them. Both experiences established strategic alliances with both public and private actors, especially with ombudsman in both countries and some specific programs that were interested in improving the quality of care. Both of them promoted audiences or meetings, gatherings with the officials, health officials and authorities to present the results of the observation and monitoring and get agreements with the local authorities and health providers to improve those pitfalls or things that were not functioning, but also to praise what was functioning to try to strengthen that. The both of them also in the analysis of the iterative processes were discovered the structural inequities that exist when a health system is attending less powered populations with lack of information on their entitlements, and the health system itself is underfunded and with serious management gaps. So among the results, we have that citizen-led accountability initiatives rebuilt indigenous populations were served by a dysfunctional publicly provided health system marked by gaps and often invisible barriers. Although funding, and there has been efforts on the countries in this, although funding and social rights to coverage have tried to be expanded, most of these for some specific marginalized populations has stayed in paper. Indigenous population in Guatemala and Peru still do not receive nor the healthcare services, nor the due protection against financial hardship promised by health systems in each country. Health systems serving indigenous population, therefore, face systemic problems with not only financing, but also in terms of management, quality of service provision, the approach itself with which they address health of indigenous populations, and lack of effective democratic mechanisms to strengthen governance and accountability, which from our point of view is the other force that could promote changes and have promoted changes in local settings, but still not in a nationwide approach. The next one, please. So what did the citizen monitoring initiatives evidence? Well, they highlighted the importance of addressing equity and how for universal health coverage and how equity could be challenged by social exclusion, historical and structural social exclusion to specific populations like indigenous people are. In this graphic, I have tried to adapt a graphic of Mario Rovere from Argentina, trying to address which were some inequities that we have detected along the years. No? So the right to health, which is linked to our objective, needs a specific equity on protection, so a person doesn't get sick, die, or live with disabilities due to preventable causes, or a person is not exposed to unnecessary health risk and lives in a healthy environment. For social marginalized population, this is not the reality. They are more exposed. Infant mortality in Peru for indigenous populations up to 2016 was 3 times the one of the national average or the urban populations. Chronic malnutrition in Guatemala was twice as bad, having bad indicators on chronic malnutrition as well, twice as bad for indigenous populations more than for other ones, with more access to health services. But this is not only due to the health causes itself, but to all the social determinants that challenge a healthy life for these populations, and being them excluded from many mainstream processes of the country, they are also excluded from higher priority in terms of resources needed, generating inequities in the decision-making on health resources. The citizen monitoring of health facilities has addressed specifically the issue of equity on health care. It's supposed that for achieving equity on health care, a person should have access to health services overcoming different barriers, geographical, financial, systemic barriers, and enough cultural respect so the services could be acceptable for them. Also, equity in healthcare involves that the person has access to good quality and appropriate complexity health services whenever needed, and that the person is not discriminated nor by race, nor by gender, language, or social or economical condition, etc. In the case of equity on healthcare, citizen monitoring in both countries have commonalities in terms of the results. There was low quality in health services provision, and this was expressed on discrimination by gender, by poverty, by race, and even Guatemala exposed cases of people that were denied attention because they were not speaking good Spanish, which is not their first language. There's been cases of abuse, cases of cultural insensitivity in terms of disrespectful attitudes towards some practices that are not harmful, but are very important to indigenous communities and people. There has been a wide range of disrespectful treatment in terms of behaviors like yelling, like forcing unwanted procedures, like not seeking for translation, not supporting them on services that they were entitled to, etc. And most of these cases had in front a person that was not aware of the rights and entitlements under the current policies. A second trend is the denial of service by different reasons, especially by not having money to pay for under-the-table payments, not having enough money to pay for services that are supposed to be given by free. No, the third trend is frequent unavailability of medicines and other exams, lab exams, and services that should be put in place at the rural areas. So these common trends of lack of access to medicines, to other services, of bad quality of health services, disrespectful treatment, discrimination within the health facilities, evidence not what we have called a day-to-day violation of their rights. That many times is taken by anecdotal, but it happens so frequently, and this has been raised by the reports that have been presented to local health authorities, that are a problem in themselves. It's not an individual problem. And there, it also reflects a high inequality on power relations that sum to the lack of information of indigenous people make them to assume or naturalize issues that should not be accepted. But probably the experiences show the need of highlighting and advocating for equity of knowledge and equity on power distribution, especially in these settings. A person needs to decide, have the possibility to decide, and for deciding have access to information needed to decide. And that's happened just after the citizen-led initiatives for the people, and then they were aware of their entitlements, the real entitlements. No, even CCTs have been used in Peru in some moment for as a method of coercion for indigenous people, in terms that they were menaced that they were going to be expelled from the program of CCTs if they don't do different things that the health providers needed them to do. Even births at the facility, which is a mandatory policy in Peru. But together with information, we need spaces, and probably this is the highest inequity existing in both systems. There are no spaces, there are no an accountability culture from the side of the hierarchical, authoritarian health systems that are health sectors in themselves. So a person needs to come with mechanisms and a power balance to decide and act on behalf of their health, individually or collectively. And this is not happening. This needs the effort of civil society organizations, and this is not unfortunately happening. The next one, please. So some ideas that we had on our discussion analyze how socially excluded groups are given fewer rights and entitlements than others. The problem of having same words but different meanings, universal health coverage, has posed a lot of attention on financial issues and less attention on access and quality and rights respect and accountability as well. No? So for some countries in Latin America, universal health coverage has been a synonym of extending universal health insurance. But as I have mentioned, and the study also analyzes this, universal health insurance coverage has happened without all the needed resources to ensure access and quality, especially for marginalized populations. The social segregation, what Ana Lorena mentioned at the beginning about the segmented health systems, also express segmented quality of healthcare for different populations. And this has been normalized. Unequal treatment, unequal financing, unequal allocation of resources is part of the health system's development in this moment. And unfortunately, sustainable development goals, measures, and indicators still provide limited support to consolidate democratic practices. They give recommendations, but there are no mandatory or more concentrated follow-up on what's happening with citizen participation and accountability that could at least change these things at the local areas like it has happened in the experiences reviewed. So just going in conclusions, Guatemala and Peru have faced challenges in consolidating democratic practices, even as their economies has grown. Many donors have left the countries of high income countries in Latin America, but there are some gaps in the puzzle that are preventing a more social equity within our sectors. Social exclusion remains embedded in the state and public facilities health practice. And civil society actors and pro-accountability actors within the state need support and institutionalized mechanisms. For example, participatory spaces for policy dialogues and accountability processes. Decisions that are made giving binding effect, providing an obligation of accomplishment. And this needs to be propelled by the state. Universal health coverage has a core element on equity, Inequity cannot be achieved if social exclusion is still determining the future of many specific groups of populations in our countries. Thank you very much.
Thank you, Ariel. Fascinating presentation on how these important initiatives on citizen monitoring can actually shed light on many dimensions of fragmented health system. Very interesting. Thank you. Now we're gonna continue with, just give me 1 second. We're going to continue with Giselle Almeida's intervention. She's the advisor in health systems and policy research at the Pan American Health Organization from the World Health Organization in Washington, D.C., where she provides technical cooperation to Latin American and Caribbean countries on policy analysis, monitoring, and evaluation processes, the use of evidence in public policies, assessment of health systems performance, and social and scientific research methods. She has extensive expertise in health systems and policy research, equity in health systems, health services management tools, evaluation tools, and project management. She's a doctor in public health with specialization in health policy and a Master of Science in Information Management with specialization in health sciences from the George Washington University. She has published extensively in books and peer-reviewed journals. So we're honored to have her in this webinar. Giselle?
Thank you very much, Pablo. Can you hear me?
Yes.
Wonderful. Excellent presentations by the panelists. Congratulations to all on very interesting articles. It's an honor to be able to comment on these articles that contribute to the evidence on the topic of equity in health and healthcare. Evidence that can inform policies and programs that seek to transform health systems toward universal health coverage. These 3 studies use very different methodologies and approaches to seek answers to inquiries about inequalities in health and access to health care. One uses a robust quantitative method that incorporates the composition and concentration indices to measure inequality in health and to inform on the progressivity of conditional cash transfers in 4 Latin American countries. Another uses case studies to illustrate how social exclusion affects access to care for indigenous groups in 2 countries, and how inclusion and social participation are key to the achievement of universal health coverage. And a third study triangulates qualitative methods by performing documentation analysis, interviews, and focus groups discussions to identify access barriers to transgender people in Colombia. I will start with the topic of conditional cash transfers. These schemes, conditional cash transfers, are powerful strategies used to address at least 2 types of inequality, usually socioeconomic, as it provides financial resources to low-income families in exchange for a specific condition that can be related to health or education. Conditional cash transfer schemes first appear in Latin America in the mid-90s. I should add that they appear to answer to the wider inequality that we saw after the health and economic reforms in Latin America that imposed sanctions to the countries and did not allow them to dedicate more resources to their health systems. So the first program was launched in Brazil in 3 different cities in Brazil in 1995. In 1997, Mexico implemented the first national conditional cash transfer program. These programs were successful and became a benchmark to fight poverty and inequalities in health and education in the region. By 2011, we had about 18 countries that had implemented conditional cash transfer programs in the region. I'll start with the first study. The first study on geographic targeting and normative frames examined equity of conditional cash transfer programs in Bolivia, Ecuador, Colombia, and Peru. The study demonstrated that socioeconomic inequalities and poverty are critical determinants of health, as household wealth was strongly associated with malnutrition and child mortality for every country and every year study. Policy and decision makers should pay special attention to two important conclusions from this study. The first one is that every conditional cash transfer program analyzed has been successful in improving health equity. And second, means testing is more effective than geographic targeting when implementing this program. So two very important conclusions here for policymakers. Moving to the second article on social exclusion and universal health coverage in Guatemala and Peru, actually it was the last article presented. This case study exemplifies that social exclusion is an important factor influencing, or I would say impacting, the achievement of universal health coverage, because groups that are excluded, even when they have de facto coverage, do not have necessarily access to quality health services for their health needs. And we know that social exclusion influences health directly through its manifestations in society, usually through discrimination, that in turn affects the health system through lack of access to quality services, that indirect affect the economic condition and socioeconomic position of those excluded, creating further inequalities and negatively influencing health. So these inequalities contribute to social exclusion processes, creating a vicious cycle. And we need to put a stop to this vicious cycle in our region. So this case study presents two citizen-led initiatives that can help break the vicious cycles. One in Guatemala and another in Peru, as I mentioned before. These initiatives are being used to inform indigenous communities of their rights and help them monitor and demand accountability for services that they are not receiving or do not have the necessary quality to be effective. Indigenous communities are good examples of the vicious cycles that I just described, as they also have very high rates of extreme poverty and malnutrition. There are reports of discrimination, abuse, cultural insensitivity, disrespectful treatment, denial of service, illegal requests for payment, lack of supplies and medicines, corruption, and neglect in both countries. The citizen-led initiatives are documenting these problems, creating the necessary awareness within the indigenous communities regarding their rights, and increasingly reporting violations and demanding accountability. It is important to note that two forces are at play that affect socially excluded groups here. First is inequity in the health system because of segmentation in financing that produces different services with different quality for the different segments of the population. And then fragmentation of health systems that creates barriers to access, loss of continuity of care, and failure of health services to meet users' health needs. The second force affecting this group is discrimination and bias, which is a societal issue that affects how these groups are treated. This bias and discrimination issue needs to be addressed as well if we are to succeed in addressing them in the health systems. For example, evidence suggests that provider discrimination exists even when the provider truly believes discrimination or bias is not present. And even when sometimes even the patient does not believe that there is bias and discrimination. We can see through the data and the service provided and the procedure utilized in certain patients that yes, there is discrimination and bias. Lastly, this study also informs the literature on the importance of community participation in policy dialogue and accountability processes, which are necessary actions to be taken if we want to transform health systems. Without the voice of the most vulnerable, progress towards universal health coverage cannot be achieved. The third and last study, which was the first study, presented on how to adapt a sexual and reproductive health service to the needs and circumstances of transgender people in Colombia, is also about social exclusion. Social exclusion of a group that has been hidden and ignored for too long. The study identifies access barriers to sexual and reproductive health services and provides information on which strategies can be used to adapt health services to their needs. These are important steps toward a more equitable health system, as trans people are vulnerable in a range of ways. For example, they have high levels of exposure to violence, mental health issues, high prevalence of sexually transmitted diseases, high consumption of alcohol and other substances, and they suffer from adverse effects of self-administered hormones, to name a few. Most importantly, this study successfully demonstrated that inclusive sexual and reproductive health programs that address the needs of transgender people can be achieved, which is a very good result here. To finalize, I would like to mention two important aspects related to all three studies. First, vulnerable groups must be identified by national, subnational, and international health indicators if we are to advance toward health equity. One study mentioned the national indicators for universal health coverage do not reflect the inequalities present in countries, which is part of the problem. This problem is known as the flaw of the averages. When average health outcomes for a population do not reflect the disparities that exist within the country and the health challenges faced by vulnerable groups. Lastly, different than other universal health coverage approaches, the Pan American Health Organization strategy on universal access to health and universal health coverage recognizes that health coverage alone is not enough to achieve universal access to health and to be inclusive. The strategy identifies 4 strategic lines for health systems to advance towards universal access to health and universal health coverage. These strategic lines address equitable access to health services, governance of the health system, equitable health financing, and intersectoral actions to address the social determinants of health. Strengthening intersectoral actions to address the social determinants of health is imperative to improve vulnerable groups' access to health services. All 3 studies presented here today fall under the recommendations for actions under this strategic line. And I will mention only 3 of those actions. The first one, generate evidence to support interinstitutional actions that impact the health of people and communities, in particular by assessing the health-related implications of policies, programs and development projects with the participation of civil society and the community. The second is strengthen the participation of the health sector in defining the health-related components of social programs, including programs for conditional cash transfer. And third, strengthen the links between health and community, promoting the role of municipalities and local grassroots organizations in improving living conditions and healthy space. Empower people and communities by training leaders, women, young people, and other community members in order for them to understand health determinants and to play an active role in health promotion and protection. Well, thank you very much for your attention. And again, congratulations to the authors on these very important studies.
Thank you, Giselle, for such an insightful presentation showing us like all the commonalities between the papers, which are clearly present between them and among the issue, the special issue. Now, I just want to remind the audience that please send us your questions via the Q&A function. In the meantime, Daniela Rodriguez will be coordinating this Q&A session.
Thank you so much, Pablo. So I want to ask all of our panelists to turn on your videos so that we can see who we're talking to and have this be feel a little bit more familiar. I want to first thank all of the panelists and Giselle as our discussant for the absolutely excellent presentations, really thoughtful and groundbreaking work that we're seeing here. I'm delighted to see that these papers were featured in our supplement because I think they really speak to not just sort of methodological advances, but really speaking to issues of equity and exclusion that are really important. And so I wanted to start with, you know, we have been living in this COVID bubble for over a year now, and you know, we have folks on the call that have been dealing specifically with things around citizen-led accountability, with the needs of trans people, and thinking about targeting of policies. And I would love to hear from the panelists, and Giselle in particular, as you have a sort of a regional perspective, how have the health systems in the region been coping with COVID, and how has it affected issues specifically around equity in service provision? And I can call on you, or you can just sort of feel free to unmute yourself and jump in.
Hello?
Yeah, hi Ariel.
Daniela, yeah. I think this is a very interesting question because somehow COVID-19 pandemic has raised some issues. First of all, it's interesting the paradox of Peru, for example, achieving or on the way of achieving the national indicators of sustainable development goals and having economic growth as well. And at the same time, having the highest rates of transmission and mortality in Latin America for COVID-19, and having a lot of people excluded from healthcare whenever they have needed to. And I think that makes us think that the post-COVID health systems in Latin America need definitely to address inequalities as a central issue of its performance metrics. There were many efforts in Peru to try to combat COVID, but there were also some limitations. And in sake of time, I will also only talk about these last ones. First of all, one size doesn't fit all. There was a lot of vision to a hospital-centric response for COVID. Almost all last year, primary health care services were closed. And that was really surprising and shocking. Many current programs have been affected, immunizations, maternal health. Actually, maternal mortality, I think, has increased 30% from 2019 to 2020. In Peru, chronic malnutrition as well, anemia as well. Immunizations fell down until November that new campaigns were raised, and now we are on the second wave. Extensive lockdown, rigid lockdown, and some urgent needed measures because of the lack of responsiveness of the health system were needed to be in place. But I think the rigid lockdown generated another social determinant that is affecting health, because almost 8 million to 10 million people in Peru lost their jobs last year. So on top of the health challenge to the health system, on top of the lack of responsiveness and trying to solve everything with complex healthcare instead of installing local systems to identify, follow up, and make a contact control of cases. On top of that, we have had an economical and therefore a social crisis as well. I think, just to conclude, that COVID-19 is showing a lot of weaknesses that we have underestimated in Peru. And of course, whenever the question comes on who is going to get the bed for hospitalization, those with less agency capacities, those with less voice, those with less presence, those who are physically far from the urban places are the ones that always are going to be excluded. And that's something that nobody's talking about. No? I think, as Giselle said, that without the voice of the most vulnerable people and the most marginalized, universal health coverage is not going to be achieved. But that voice, as Jonathan Fox says, needs teeth, needs structures that could support that voice to be effective and make real changes on the health system.
Thank you so much, Ariel. I wonder if anyone else wants to come in on this.
I just have a quick comment building off what Ariel said, which is, I think it says a lot about linking social benefits to employment. And I think that's a commonality across Latin America, Caribbean, and even here in Canada and the United States, that because of COVID, people have been unemployed, not because of their fault, in mass numbers. And we've seen the risk of tying health insurance or other social protection programs to being employed. Conditional cash transfers are one of the few programs in Latin America that are really universally distributed across the country, regardless of employment status. And so in that way, I think they offer a model of what could be done to strengthen health systems across the region. And even here in Canada, we've had targeted cash transfer programs where people have been looking at the experience of Latin American countries and what we could be doing to provide both cash and health benefits to people who need it in a progressive manner. So that's my quick comment.
Thank you so much. Mariana, any thoughts coming from the focus on sexual and reproductive health services, which we know have been massively impacted by these closures?
Yes, just a little comment also. What we have seen is that COVID has changed, of course, our priorities, but also has sent like a weird message that sexual and reproductive health needs are not urgent. So what we are seeing is that people is waiting a lot of time before going to services. And I think that what we have to do is keep sending the message that even though we have to protect from COVID, we also have to keep in our minds that we have sexual and reproductive health needs that cannot wait in order to prevent STIs and abortion or unintended pregnancies.
Yeah, thank you so much. And I'm sure actually there's a lot to explore there around the fact that sexual and reproductive health services tend to be targeted at women or gender minorities, and sort of whether those things get prioritized over other things that that serve other parts of the population. Giselle, any last thoughts here before we turn it over to Daniel?
Sure, absolutely. So I'm going to make a general comment, not specific to any country, but I think COVID-19 show us the fragility of health systems that we have in the region, and how health and the economy are intertwined. And that brings me to a topic that we discussed in the Health Systems Global Conference in Canada, in Toronto, in 2016, that was about resilient health system. And we talked about, and we had discussion with the countries, because we will continue to have not only pandemics, but disasters, natural disasters, political instability, social instability, and we need to create health systems that are resilient to that. And we also noticed that how even a strong health system that doesn't have very good governance, or it's not supported by policies and politicians, can fail the public. And another thing that I think it's very important for the topic we are discussing here today is how this type of crisis and how fragile health systems affect the most vulnerable. Mm-hmm. We have seen in almost all countries in the region that fatality is among minority groups. The highest mm-hmm. levels of fatality and infection is among the most vulnerable, but they are the least to receive, they are the last ones to receive treatment and the last one to receive vaccination. So we still have a long way to go. And another thing that helps resilience is integrating priority programs in health with the health system. Instead of having just specific response for specific disasters, make sure the health system will be able to answer the needs of the population in distress situation like COVID and other emergencies that we will have in the future.
Thank you so much, Giselle. And I know we're almost out of time, so I'm going to turn it over to Daniela in a minute, but I just want to thank our panelists again. And I want those of you in the audience, if you haven't seen it, please check out the supplement. This is only but a small sliver of the really interesting and excellent work that's in the supplement. So with that, I'll turn it over to Daniel to wrap us up.
Thank you, Daniela. Thanks the presenters. Thanks my great co-editors of this special issue, and particularly to Giselle for her very interesting insights. I'm proud of being part of this initiative. I love to have the International Journal for Equity in Health as a key partner of Health Systems Global in developing a strategy to disseminate the Latin American Caribbean work all over the world. And as chair for the Americas within the board of Health Systems Global, I want to invite you to our next symposium, which is going to be taking place for the first time in the region, Bogota 2022. We will be start discussing the themes and sub-themes that will trigger the debate in the symposium, and we are planning to open a lot of channels of communication between the board, the program working group, and the members to start receiving your inputs about what would be the topics that we want to discuss. It's going to be a link in our society's webpage where you can send us your comments, and also our Latin American and Caribbean Secretariat has a Google group where we will be calling you for your suggestions, and also open this discussion. We have like a few months to prepare the themes and sub-themes before sending them out to the rest of the members. And also we're trying to keep having our series of pre-conferences and during the pandemic, so probably we will be hearing from us to see how to prepare those events, either face-to-face or through webinars. So thank you very much again, and I think that this is it. Hope you have a great day, and hope also to see you very soon as always. Take care.
And please note that the recording of the webinar will be available online. We'll be sharing that through our different social media channels. So please do check it out if there was any section that you missed, and we'll also make sure to link to the supplement. Thank you so much, and I hope a great rest of your day wherever you are. Thank you for coming.
Thank you. Bye-bye.